We will continue, and it's my pleasure to announce now Mr. O'Hara, Jamie O'Hara from Adelphi in UK, and he will now talk and give the first presentation on assessing the burden of neuropathic pain to support the uptake of good practice indicators, insights from real-world data across different diseases. So he will present us the results, I think, of an analysis and research on these aspects.
Yeah, it will be based on the qualitative analysis to date, and the final report will be made available on the SIP website, which will include some costings and whatnot. Okay, so what I'll try to do today is summarise some of the findings that we've made. Probably be helpful for you to understand who I am and where I'm from. I'm a health economist, and I specialise in health economic evaluation, and I've built burden of illness studies across many different types of disease areas, and this is the first time I've been asked to build one within neuropathic pain and pain generally. Okay, and within Adelphi, our raison d'etre, so to speak, is the development of real-world databases, and in 2011 to 2012, we built one on neuropathic pain. Okay? This database was initially built to support the GPIs, which have been developed by yourselves, and we've subsequently taken the opportunity to use the data in order to better understand the unmet need within the subgroups of neuropathic pain, a lot of which overlap with the subgroups where the GPIs are currently focused. Okay, and why is this a good idea? Effectively because we have a homogeneous data collation methodology, not only across countries, but across many different disease areas. Okay, and we feel this would provide some useful messages so we can better understand the relative burden of neuropathic pain and some of the subgroups compared to some other more publicised disease areas. Okay, so I think it would be quite useful to understand how we collect our data. And we begin by, first of all, recruiting physicians in various different countries. And we then have an attitudinal focused interview in which we can better understand their understanding of the treatments available and the current care pathways available to these types of patients. We then learn more about their workload, so we can understand traditionally and conventionally what their workload looks like in terms of the types and numbers of patients they will see in a set period of time. We then ask them to complete a patient record form for their next 10 consulting patients, which is a comprehensive survey of their next 10 patients, where we learn more about their treatment algorithm, where we'll learn about their treatment history, as well as their relative needs compared to some of the patients they might see. And of those 10 patients, all of those are then invited to complete a patient self-completion form, which is populated with patient-reported outcome instruments or validated instruments and other things that will help us better understand the impact of the condition on a patient. And we, on average, get between 500 and 600 variables on each patient from both the physician and the patient, so it's quite a rich data set. For this particular database that we're building the current burden of illness study on, this is the makeup of it. It's across the 5 EU countries, and we have just under 4,000 patients completed by the physician and just over 2,500 patients completed patient self-completion form. So we've got quite a rich granular data set upon which to build this study. And something I didn't anticipate was the fragmentation within pain. It's a very complex disease area, as I'm sure you're all aware, but having built studies like this in different disease areas, I was surprised and somewhat upset at having to build such a large study. But we look at all these different subgroups within our study. And just to show, we also run this type of study across many different disease areas. If you look at the top right, there are pain studies that we have. Okay, so we've used this data to build a bottom-up burden of illness study, and for the uninitiated in the room, a bottom-up burden of illness study is effectively where we take data from each individual patient to build a holistic overall picture of what that burden is to the patient and society as a whole. Okay, so the type of data we've taken is the direct resource utilisation, the direct non-medical resource use, the indirect resource use, and we've also captured several validated PRO instruments from our participating patients. Okay, so hopefully this is making for a genuinely holistic burden of illness study, which what this whole initiative is about. And why is it important? I'm sure you'll know the reasons, but working in health economic evaluation and with HTA assessments, these are almost exclusively and very narrow in the way that they look at direct resource utilisation, which is only a very small part of the issues that surround neuropathic pain, as well as some of the disease areas. Okay, so we hope to provide some insights into the wider cost of society, as well as our conventional direct resource utilisations. Okay, because as society, we collectively have a bottom line. Okay, so of our 4,000 consultant patients, we have just near 37,000 consultations with PCPs and specialists, okay, which is a fantastic amount of consultations. On average, that's 9.3 per patient per year, and the split of this is approximately 60% specialists across the 5 EU, different countries, and 40% across for PCPs and GPs across the EU too. Okay, and something in our analysis, obviously we've got to summarise it somewhat. We found that the patient-reported outcomes are particularly sensitive to these resource usages, and if we look at one of the instruments we've captured is the EQ5D, which is the health-related quality of life instrument. So higher is worse, higher is better, 1 being perfectly fine, and 0 being, as bad as you can get, as it were. And BPI, the brief pain index, which somebody alluded to before, is a positive scale. So the higher you get, nearer to 10, it's the worst pain imaginable. Okay, and these are some of the subgroups and the average EQ5D scores, and you can see there's quite a high variance amongst these groups. Okay, and the same with the BPI. Okay, something else that we've been doing is interquartile analysis. So this is effectively, we create a league table of the worst recorded EQ5Ds relative to the best recorded EQ5Ds. And in the first quartile, which are those that have the worst quality of life, we see that there is an inverse relationship with the number of drugs that they're prescribed by a physician, okay? And it's quite a nice pattern running down too. So those who have the best quality of life tend to consume fewer drugs on average, okay? And if we look at mean consultations, there's also quite a similar pattern. We've done this in deciles too, and it gives a more granular output. But the pattern is there, and you can clearly see by the trend line the propensity to use, the propensity to have more consultations reduces as your quality of life improves. Okay. We also ran the same analysis for BPI, the interference measure, and you can clearly see the lower the quartile, obviously the lower the pain experienced by a patient, and the higher is the worse the pain experienced by a patient, and you can see the positive relationship again. So the worse the pain, the more drugs they're likely to consume, and the more consultations a patient is likely to have too. Not just, that's the same pattern arises in non-specialist and specialist consultations. Okay, so one thing that we've been considering is, so what drives better outcomes? Because we want to understand what can improve people's lives. And these are built on regressions, and for those who understand this kind of analysis more in the room, we've confounded them for severity, age, gender, and a few other things. But we looked at adherence. We asked each patient how adherent you are to your treatment. We've also done the same with the physician, and we got very similar outcomes. The more adherent patients are to their prescribed care pathway or their treatment and drug use, then the higher quality of life they are likely to enjoy. And if we look at the heat map on the right-hand side, or the contour plot, if you look at the vertical axes, this represents the time from reporting their symptoms first to actual diagnosis. And the closer we get to red is the worse the quality of life endured by that patient. Okay, so we can clearly see that there is a positive relationship between the amount of time to diagnosis and the quality of life. So the worse the quality of life, it's usually an indicator that they've taken a long time to be diagnosed. And the same with treatment switches. The more chopping and changing that's done with regards to the treatment the patient is on, the worse the quality of life tends to be. Okay, and again we duplicated this analysis for BPI. So those who are not adherent tend to endure much higher pain levels than those who are adherent. And again, the level of pain experienced by patients is highly sensitive to the amount of time it takes to be diagnosed with whatever your ailment is. And the number of switches also acts as an indicator as to what makes pain worse. Okay, so some of the wider things that we've looked at are caregiver burden. Within our sample, we found that 755 of our patients actually had a caregiver, which is just under 20% of the overall sample. And the highest number with caregiver is in Italy, and the lowest number is in France. And of this group of 755 caregivers, these are 89% made up of non-professional caregivers, which means it's partners, friends, family, or a volunteer who helps out. Okay, so this kind of gives an indication as to the wider impact, because not only are we losing working time from the actual patient, but also from the people who are helping them. Okay, and again, this is highest in Italy and lowest in France. There seems to be a pattern where France cares less. Apologies to anyone French. But the average number of hours of care provided across the EU by these caregivers is highest in Italy, which is 48.7%. Overall for the sample is 48.7 hours of treatment per week, whereas in total for our overall sample, it's an average of 27.5 hours per week. So this is quite interesting, because when we run the figures and multiply by the amount of hours given up to provide care, we found that there was an opportunity cost of 41,318 hours, or in a more digestible format, 5,165 days of work were lost by the caregivers alone, which obviously this is only within a sample of 755. When we begin to extrapolate this into the incidence and prevalence figures, the numbers can be quite mind-boggling. Okay, and some of the relative findings have been the working population, which is those in full-time, part-time, or in self-employment. We can see that for all neuropathic pain patients, only 34.5% of our sample are actually part of the workforce. And if we look in other indications such as PHN and DPN, these are really low and comparable to other disease areas such as COPD, diabetes and rheumatoid arthritis. And we can clearly see that some of these, obviously the higher the worse, as it says in the graph, we can see that there is substantial impact on society relative to some of the other disease areas that we've listed. Okay. And when we look at the EQ5D, we've taken some more data out of some of our other programs, and we thought this was quite striking. We haven't adjusted this because we want to keep it real world, but this is the average EQ5D score for the cohort of patients in each of these programs. And if we look at the overall for neuropathic pain, it's 0.58, which is relatively, well, about average for the overall. But we look at fibromyalgia, lower back pain, PHN, PSN and radiculopathy, and then compare it to the cancer, the 3 cancer studies at the end. The quality of life seems to be comparable with some other definitely more highly publicised disease areas, indicating an effect. Okay, and just to conclude, the study is not finished and it will be available on the SIP website, but just with the qualitative research we've done so far, there are significantly high levels of unmet needs, particularly when comparing it across other disease areas, not only within the overall sample, but specifically within some of the fragmented samples that we have. And as a group, neuropathic pain, and even particularly in some of the subgroups, including PSN and PHN, some of those characteristics are quite comparable with those of other disease groups that might receive specialist commissioning, may have specialised designated care pathways and enjoy care pathway bundling for better, more efficient care. Okay, and we feel that there's more analysis, much more analysis to be done to understand more, because the more granular the analysis, the better understanding we can have of the root cause of these poor outcomes. And one of the big findings we've had is the opportunity cost of poor upfront diagnostics. So we feel there's a lot of work to be done there for good quality indicators, good practice indicators, whatnot, to improve diagnostics, because this seems to be a major driver of poor outcomes and therein cost to society. And we would like to thank you for involving us, because we feel the engagement of public, private and third sector organisations together really can make differences. And thank you. Yeah. Yeah.